professor and chairman of the Department of Urology, School of Medicine, Gunma, and also a professor in the Gunma University Heavy Iron Medical Center. Now he's gonna talk about some heavy iron therapy for prostate cancer in the Gunma area. Thank you.
Thank you very much for kind introduction, Professor Am. I'm glad to be here, and thank you very much for Professor Chan to inviting me to this meeting. I'd like to share my experience for the heavy iron radiotherapy for prostate cancer briefly. So, for radiation therapy, like IMRT, we use the photon. It's very small X-ray. Then for particle therapy, we have proton and heavy iron. The proton is the molecular weight, if it 1, and then carbon is 12. Then the proton or carbon is accelerated to hit the cancer cells. The significant, most typical aspect of the carbon or proton is the black peak. Usual peak of the X-ray is about 2 centimeters from the body surface. However, the proton or carbon, the peak energy is about 10 or 8 to 12 centimeters from the surface. So if the target is located relatively deep in the body, like prostate, it is beneficial for the this target to prevent some adverse event. And this is the scheme for the pituitary gland tumor. For X-rays like this, and the proton like carbon can very steep area distribution like this. And this is for lung cancer. Using the stereotactic radiation, the radiation volume for the lung cancer is very high. However, the normal lung tissue have some degree of radiation. Then for carbon or proton, the normal lung tissue spare the radiation like this. And another aspect of the carbon iron is the DNA strand break. The usual X-ray cut the single DNA strand, and then carbon iron cut the double strand to prevent the DNA recover. So biological effectiveness or dose distribution, carbon iron is thought to be excellent like this. In our university, the heavy iron medical center has been developed in 2010, and almost 8 years have passed. In Japan, the first center for particle therapy is developed in Chiba National Institute Radiation Research. Then next is Hyogo, and the third is our institute. Then after 3 years, the Saga is Kyushu, and then Yokohama, and also recently Osaka developed the carbon ion radiation center. So now 6 institutions are in operation, and one institution under construction in Yamagata. For prostate cancer, the total 57.6 grade per 16 or 12 fraction irradiated. This figure is relatively smaller in compared to the normal IMLT radiation dose, but this figure is like about 80 grade for the normal radiation. The dose distribution is like this. Then we started the treatment in 2010, and then first protocol is Gunma 0702. We started the treatment by using the 16 fraction, and recently we switched to the 12 fraction. Originally, this carbon ion therapy has been approved for as a clinical trials. So all the treatment patients are enrolled in the clinical trials. So first I summarized this first study data, because median follow-up treatment has over the 5 years. For patients with low risk or Gleason score 3+ for patient we don't use the concomitant ADT. Then for intermediate patient with 4+3 patient use the neoadjuvant 6 months ADT. For high risk patient, total 2 years, and recently 1.5 years. The first study was consisted of 304 patients. Most patients are intermediate and high risk patients. The median follow-up is 16 months. This is biochemical failure free rate for total patient. 5-year biochemical failure rate is biochemical failure free rate is the 92.7%. Then this is based on risk stratification for the low, inter, high risk. Maybe there is no significant difference among the risk stratification. The patient with Gleason score 9 or 10 showed the worst progression-free survival rate, like 5 years. Gleason 6, 7, 8 is about 94, but Gleason with 9 or 10 patients showed the little bit lower, 80%. And this is T factors did not show any difference. This is also ADT plus or minus, no difference. Overall survival showed the 5 years is the 96.6%. Local control is showed no difference between the T3B or T3O or T2. And this summarized prognosis. The local recurrence was found in 1.3%, and distant metastasis was found in 2%. Then prostate cancer deaths occurred at 1%. This table summarizes the adverse event of in this study. So in acute phase, grade 2 genitourinary adverse event was 4%, and rectal was none. Then in late phase, 9% of patients showed the GI adverse event in the max phase, and one patient showed the grade 3. Grade 3 patient underwent the hyperbaric oxygen therapy for radiation cystitis. For rectal adverse events show no severe complications. So far, we treated 1,500 patients for the prostate cancer. We combined the analysis of these 6 protocols. So this is total biochemical failure-free rate. The median follow-up time is about 3 years. So 5-year biochemical free rate is 92%. And then the background of patient with PSA failure is shown in this patient. Like 56% have the high risk and 34% intermediate risk. And some patients without concomitant ADT have the PSA failure like this. Then 9 patients died from the prostate cancer deaths. Prostate cancer, 2%. Then all the patients have the high risk for the patient with prostate cancer deaths, and then also Gleason score is 9 or 10, as shown in this slide. Local recognition, okay. So in this 1,500 patients, total 5 patients had the grade 3 adverse event concerning the genitourinary complications. 2 patients have the hematuria grade 3. It needs the electronic coagulation. And then 1 patient had the urethral strictures need dilatation, and 2 patients had the urethral stricture need WS stent. This case is the urethral strictures post 2-year radiation. Patient showed the urinary disturbance, and endoscopy showed the membranous stricture of prostate urethra. But this stricture is not so hard, and the length of the stricture is very small. So by endoscopic hysterectomy, the patient leaves like this. This is the patient with the urethral stricture. Maybe this is caused by the irradiation to the urethral internal orifice. Then CT scan showed some a little bit dilated ureter like this. Then we put the WS stent to this patient, and then after a few months later, we removed the stent, and then patient lived well. So our data is relatively good. So the multi-institutional retrospective observation study was conducted to validate of the each institute data or like this. Chiba, Gunma, and Kyushu data was collected. The total 2,300 patients analyzed. So Gunma, Chiba, Kyushu saga. The high-risk patient have the about 60%. The PSA-free relapse-free survival rate like this: 5-year high risk for 90%, and 10-year 80%. 10-year data is basically from the Chiba. So local control rate is good, and then survival rate is similar, and the co-specific rate is good. Then overall survival rate is relatively low in the high risk group. Toxicity is similar to our institute. So multi-institutional retrospective observational studies conducted in the current study showed a favorable result of especially high risk group and low possibility of late GI toxicity. So final topic, just brief mention the effect of urinary function in our study. So first studies consist of 300 cases analyzed. So this is prostate volume change. The red bar is the without ADT. Then red bar is the short ADT group, and the long-term ADT group green. So after 1 month, so gradually prostate size shrink after radiation. Then this is flow data. After the just termination of the radiation, the Qmax or voided volume is significantly worsened just after the radiation. But after 3 months or 1 year, it recovers like this. Then, so association of the alpha, if patient have the alpha blocker, the baseline is slightly higher, so it helps to patient to suffer from the urinary disturbance. Then last April, the Japanese government decided to cover the heavy ion radiation therapy for prostate cancer as a public health insurance. The cost is almost same as the IMRT. So in summary, the efficacy of heavy ion radiation therapy was effective for locally advanced prostate cancer. Low rate of adverse events are confirmed in our protocol and other protocol. Especially oncologic outcomes of high-risk patients are excellent and through heavy ion radiation therapy. Thank you for your attention.
Thank you for the very